So our final speaker for the afternoon is Chrys Pulle. So Chrys Pulle's a geriatrician. He works up in Prince Charles in Queensland. And the reason Chrys is presenting is because Prince Charles is one of those exemplar sites that we like to highlight and hopefully learn from in terms of how they're managing secondary fracture prevention. So welcome, Chrys.
Thanks, Jackie. Quality Statement 6 is minimising risk of another fracture. So we know that 1 in 3 hip fracture patients will refracture at 1 year. There's a large body of evidence to support secondary fracture prevention through treatment of bone health and falls prevention strategies to reduce falls fracture. Which models of care can significantly reduce the risk of further fractures, pain, suffering, hospitalisation? So they include systematic identification of at-risk patients, investigation of risk factors for future falls and fractures, and individualised treatment plans for falls prevention and treatment of osteoporosis. So the approach is cost effective. I'll first start with the good news in terms of the ANZ HFR data. So in Australia and New Zealand, 72% in Australia and 76% of all patients receive specialised falls assessment. So this includes suitably trained health professional to cover falls history, risk factor for falls, including medication reviews and formulation of plan to prevent further falls. It is also recognised that a specialist falls assessment is not always possible in the acute hospitalisation period. Turning to the not so good news. So from the 2020 ANZ HFR report, we know that 27% of patients were on active treatment for osteoporosis at discharge from hospital, and 26% of hospitals routinely provide individualised written information on the prevention of future falls and fractures. So the majority of patients admitted with a hip fracture were not on any form of pharmacological treatment for bone health prior to their fracture. This is despite evidence demonstrating that up to 50% of these people will have already sustained a minimal trauma fracture, and fracture prevention services effective in reducing subsequent fractures. So this slide shot from the 2020 report shows that in Australia and New Zealand, approximately 61% of patients were not on any medication to protect their bones prior to hospitalisation, and only 9% were on an anti-resorptive or teriparatide. And this proportion suggests a significant ongoing care gap in secondary fracture prevention in both countries, and a care gap that has been resilient to change over the 5 years of reporting. When patients are admitted to hospital for their hip fracture, does this improve? You would hope that it would, given that we're in an orthopaedic or orthogeriatric setting with medical input. However, in Australia, only 25% of patients left hospital on a bisphosphonate, denosumab or teriparatide, compared to 9% on admission. So whilst there's an improvement, there's still a significant fracture gap, and these patients with subsequent risk for future fractures. Now, there is incredible heterogeneity in some of the better hospitals. Thankfully, we are one here at Prince Charles, which up to 65% of patients are on some form of anti-resorptive treatment, whereas in a lot of hospitals, it's under 10 or even 20%. How do we do in terms of state of origin? Well, South Australia and Queensland are the leaders with 46% and 38% of patients discharged on anti-resorptives or teriparatide. Unfortunately, the bigger states, New South Wales and Victoria, are lagging, with New South Wales at 20% and Victoria at 16%. Now, since the ANZ HFR has been instituted, there have been a number of increasing in services for post-fracture review. So fracture liaison service, access to falls and osteoporosis clinics, access to falls and bone health clinic, and even orthopaedic clinic is listed here. And this has improved significantly over the period of time to up to 40% of patients on fracture liaison services or falls clinics. And so you would hope that this would increase bone protection rates. This is a tabulated form of the previous slide. So where are we in terms of bone protection at 120 days? So in Australia and New Zealand, in Australia, about 38% of patients are on bone protection at 120 days, even though only a minority of sites have follow-up for these cases, whereas in New Zealand it's about 45%. How do we compare internationally? Well, in the UK, it's approximately 55% on the National Hip Fracture Database, which has been instituted for over 10 years. And in Spain, we're sort of equivalent between 15 and 36%. Other registries report access to bone protection as opposed to actual hard data in terms of medication. So turning to the local example for which we were acknowledged. So Prince Charles here is the maroon for Queensland, green is Australia and black is New Zealand. So medication rates on admission are similar to other sites. What about medications on discharge? So initially in 2015-16, when the ANZ HFR showed de-identified hospitalisations, our rates were very poor on discharge. Even though we are a shared care model with geriatric medicine input. Once the ANZ HFR de-identified hospitals, this was a rude shock to our site. And so we looked at strategies to try and improve osteoporosis medication on discharge. So we improved from 15% to 30% to now over 65%. And does this stay, does bone protection medication remain on at 120 days with follow-up? Yes, they tend to stay protected depending on the type of medication that's been administered. Just turning to our local unit, it's a shared care model established in 2010 that services the Metro North Hospital Health Service in Brisbane. It covers approximately 1 million patients, 1 million residents, sorry. We have 300 to 400 hip fracture admissions per year. And in our hospital itself, there is no fracture liaison service nor an osteoporosis clinic within the hospital. There is one at the Royal Brisbane Women's Hospital, which is 10 kilometres down the road. So how do we improve strategies to improve bone protection medication? Well, it was quite simple. We developed a collaborative with the pharmacists who are involved in this project to improve simple clinical handover. So not only was it in terms of osteoporosis management on discharge, but also VTE, prophylaxis and opioid reducing plan, which the previous speaker enunciated too. So when patients were discharged from our acute unit or moved to subacute services, rehabilitation, GEM unit, transitional care or return back to the nursing home, this management plan was instituted. And it was simple prompting of the junior medical staff on discharge in terms of osteoporosis management, where that led to increased medication discharges. Traditionally, what have been the barriers to secondary fracture prevention? Well, essentially it was residential aged care. Patients have a deep, practitioners had a deprescribing view, and osteoporosis medication is one of the first medications that was thought was non-essential. But increasing enough, patients in residential care are living longer, and if life expectancy is greater than 6 months or 12 months, then they should be prescribed osteoporosis medications. There's been a lack of knowledge in terms of benefit versus risk. There are at times patients with severe dementia that are not able to take oral medications, and also the presumed potential perceived risk of osteonecrosis of the jaw or atypical femoral fracture, which are less than initially feared. Back in 2012, refractures cost $223 million. I suspect this has increased significantly over the past decade, but refractures of hip fractures are about 4,000 patients almost, costing about $104 million. So this is a simple initiative that aims to try and reduce fracture. So in conclusion, bone protection medication rates are low across the Australian New Zealand Hip Fracture Registry as shown by the data. I think hospital identification was an instigator here at Prince Charles Hospital to try and increase rates of bone protection medication. So I think it's important to collaborate with multidisciplinary colleagues in order to try and make this happen on the ground level. As geriatricians, we're always keen on bone protection medications, but I think sometimes it's not filtered down to the resident level. Fracture liaison services and osteoporosis clinics where present are beneficial, but in the absence of these services, I think simple measures in terms of clinical handover are important. Hopefully the electronic medical record and discharge summary, as well as My Health record, will improve this. But I think what's been shown that if medications are not initiated within the acute hospital setting, then they're less likely to be initiated in the general practitioner setting. So I'd like to acknowledge Elizabeth Armstrong from the slides in terms of the Australian New Zealand Fracture Registry in terms of bone protection rates. I'd like to acknowledge our pharmacists involved in the project, Erin Dunn, Richard Bolitho, Prue Bryan and Rachel Cathcart, and my fellow geriatricians and rehabilitations at Prince Charles Hospital that instituted this project. And this is a picture from the Hip Fest from 2 years ago at Prince Charles Hospital, where we had a face-to-face event. I think we've got the same number of attendees virtually today. So thank you.
Great, thanks very much, Chrys. A number of questions coming through, so I'll just do the most common ones first, and then we'll work out a way of sharing the answers for the rest of them later. So, patients with bad dentition. Now, of course, bad dentition means different things to different people. Do you wait for formal dental reviews before starting anti-resorptives?
Not routinely. Certainly patients with very poor dentition, they should be considered for pre-dental review, but as the data shows, the rates of osteonecrosis of the jaw are very low. Most of the rates of osteonecrosis of the jaw are for patients on higher dose bisphosphonates or IV bisphosphonates for oncology dosages as opposed to bone protection.
Yes, I think we do more harm by putting it off and waiting a dental review. And then
exactly, they don't get initiated, I think.
Correct, yeah, absolutely. Another question, if a patient has a hip fracture when they're already on bisphosphonates, what are the next options for refracture prevention?
Well, secondary prevention is a problem. I'm not an osteoporosis expert, but certainly there is certainly vitamin D should be checked to make sure that vitamin D levels are appropriate. They have supplemental calcium that's appropriate, and they could be considered for changing to something like denosumab or Prolia. I know the romosozumab has just been initiated, but that has severe restrictions. So at this stage, I think we would consider changing to a subcutaneous administration of denosumab.
Thanks. Last question, and apologies for those that I can't ask. What do you think are the main barriers to hip fracture patients being prescribed bone protection medication in hospital?
I think a lot of the barriers are concerns, for instance, like dental assessments, concerns of atypical femoral fractures. Thankfully, I think our orthopaedic colleagues are not as concerned as they used to be. But also, I think in terms of, as that previous slide, the concern that these patients have a poor quality of life, or they've got deprescribing issues, or simply that it's just missed in the acuity of these patients in their pending discharge, that it's missed, or in terms of timing of administration of medications. And I think that's why subcutaneous administration will last for 6 months, as opposed to oral therapy where patients are often not compliant or adherent.
Okay. Chrys, thank you very much, and congratulations to Prince Charles on being an exemplar site. I hope many of you have taken away some ideas as to what you might do locally to increase your rate of treatment for osteoporosis.